Okay, next we have Dr. Sharon McAuley. So Sharon will be presenting on findings from a multi-incident review of serious paediatric clinical incident reports in Queensland. Sharon is a senior staff specialist in paediatric emergency at the Queensland Children's Hospital here in Brisbane, Chief of Critical Care Children's Health Queensland, and Chair of the Queensland Paediatric Quality Council. She's also a senior lecturer at the University of Queensland. Oh, Jodie's joining us as well. Sorry. I had noticed that Jodie wouldn't be joining us, so apologies there, Jodie. Jodie's coordinator of the Queensland Paediatric Quality Council. And Jodie is the coordinator and principal project officer for the Clinical Incident Subcommittee within the Paediatric Quality Council. Prior to this, Jodie was involved in research on childhood injuries as part of a longitudinal birth cohort study at Griffith University. Jodie's area of study was in behavioural science, and has worked across government, community and university sectors. Sorry, we got there in the end. Over to you, Sharon Ann and Jodie. Thank you. You're just on mute there, Sharon.
Can you hear me now? Hopefully. Thank you very much, Chris. And thank you all. We really appreciate coming here and having the opportunity to share our information and work. I'll just see if I can get the presentation up. Hopefully you can see that. Fantastic. Great. So my name is Sharon Ann McAuley. I work at the Queensland Children's Hospital. I'm chair of the Queensland Paediatric Quality Council, and also an emergency physician. And with me, we have Jodie Osborne, who has, we originally planned to present together, hence Chris, the change, but due to COVID, we're split. So Jodie is the project coordinator of our clinical incident subcommittee, and we're presenting some findings of our multi-incident reviews of serious paediatric clinical incidents in Queensland, the 2015 to 2019 report. So before we begin, I think it's important that we acknowledge the lands upon which this meeting is taking place for us. So for me, it's the Turrbal and Yuggera peoples, and I would like to pay my respects to the elders past, present and emerging. Thanks.
Okay, so I'll take over for a short while, but just as a bit of background. So we are the Queensland Paediatric Quality Council. We're a quality assurance committee that was established under the Hospital and Health Board Act 2011. And our primary responsibility is to collect and analyse clinical information regarding paediatric mortality and morbidity, and to make recommendations at the statewide level to improve patient safety and care. We're just a small little team of 4 people, and Diane Cruz, who's on the infant mortality subcommittee, is here listening today. And we have 2 major bodies of work. So we have the Infant Mortality Subcommittee, who looks at the causes and contributing factors for infant mortality in Queensland. And I know they presented at this conference last year on the Safer Sleep guidelines. So you'd be familiar with their work. And ours today, which we want to focus on, which is the Clinical Incident Subcommittee. Thanks, Sharon Ann. So the Clinical Incident Subcommittee, what this committee does is we review serious adverse clinical incidents in hospitals involving children under 18 years of age in Queensland. So for those who may not be aware, a clinical incident, it's an unexpected event arising as an outcome of healthcare which causes or may cause unintended harm to the patient. In Queensland, all our clinical incidents are categorised using a severity assessment code, with those resulting in death or likely permanent harm being categorised as SAC1 and temporary harm SAC2. For our clinical incident research, we focus particularly on the SAC1 incidents, so those resulting in death or permanent harm, but we do look at SAC2 events when we do our themed reviews. So when a clinical incident occurs at the local hospital and health service, they will undertake what's known as a clinical incident review. So they reinvestigate the incident, looking for factors that contributed to the incident and to make recommendations to ensure that it doesn't happen again. And while those learnings are really valuable, they're rarely shared outside of the hospital and health service that did the review. That's where we come in. What we do is we collate together all the clinical incident reports from across the state, and we do a retrospective review of these reports, not to reinvestigate the incident, but to look for common themes and statewide opportunities to improve patient safety and care. Our committee also has a look at the quality of clinical incident reviews to provide feedback to HHSs. Thanks, Sharon Ann. Our clinical incident subcommittee is an amazing volunteer committee, which is comprised of multidisciplinary and statewide representatives across Queensland Health and our partner organisations. So at the moment, we currently have emergency specialists, we have paediatricians, we have surgeons, we have intensivists, we have human assistive factor experts, retrieval experts, nurses, we have general practitioners. So it's quite a lovely, diverse group of people who all volunteer their time to help us do our reviews and to make recommendations. Thanks, Sharon Ann. For our process, we identify all our SAC1 clinical incidents from the RISMAN database, which is coordinated by Patient Safety and Quality Improvement Service. Once we identify those clinical incidents that are relevant for our committee, we request all the report and documentations from those reviews from Patient Safety or the local HHS. If the case involves the death of a child, we also collect coronial reports from the coroner where applicable. These documents are reviewed by two. Oh, sorry.
Apologies.
That's okay. These documents are reviewed by two members of our panel, both individually and jointly using a multi-incident analysis tool, which we've adapted from a number of resources, including a New South Wales taxonomy. And what our tool does is it assesses the demographic profile of the incidents, any patient, facility, human and system factors that contributed to the event. And once the two panel members have had a look at it, we actually present each case at a monthly meeting so that we can get some consensus and also discussion around what's happening in the case. Sometimes as we're doing these reviews, we start to become aware that there's cases that we think we've heard before, but it really is just similar themes happening across the HHSs. And when we notice that, for example, one area was in testicular torsion, we will actually re-review those cases as a cluster and bring in subject matter experts to help us with the reviews. Thanks, Sharon Ann. I'll hand over to you.
Thank you. The report, which we can make sure we share afterwards, so everyone has a copy, or they can go on our website. But it covers the time of 2015 to 2019, and we reviewed all the SAC1 cases for all children under the age of 18 years in Queensland. So 174 SAC1s, so either permanent harm or death, were identified on the RISCMAN database. 101 were out of scope. So there, any events that involve birth events, mental health incidents, anything that occurs outside the hospital setting, statutory reviews, so criminal reviews, SAC level downgrades. So occasionally something will be called a SAC 1, and then when they've reviewed it, it gets downgraded, and any duplicates. So that left us with a total number of 73 incidents that we reviewed, which gave a mean number of incidents each year of 15. Patient profile, I think none of this will surprise you. There's an overrepresentation of the younger age groups. So even though only 25% of Queensland's population has children under the age of 0 to 4, in fact, 63% of our cases involve that age group. And half of those, that 63%, were in children under the age of 1, so they are most certainly vulnerable. We had about a 51-49% split in gender. The patient outcomes, so over 2/3, resulted in likely permanent harm to the child, and 32% in death. And a quarter of our cases, the patients or families identified as being Aboriginal or Torres Strait Islander background, even though our population estimates are 7%. With regard to the facility profile, so in Queensland, there are 16 hospital and health service hospital and health services. 13 out of 16 reported SAC-1s. That doesn't mean that some are better or worse. It just speaks to the reporting culture. Having said that, there was the percentage of clinical incidents in the combined outer regional, remote and very remote areas of Australia, where it was 32%. And so that was nearly double, in fact, double what it should have been if you compared it to the actual population estimates. So looking at the incidents involving the death of a child, we had 23, 65% were due to sepsis, so much so that we, as a subject matter expert, we invited Paula Lister to be involved in our review, and we're very grateful for that. 22% were of cardiac origin, and 13% due to sudden unexpected death in infancy. This graph shows, the contributing factors. So delayed recognition and response to deterioration occurred in 83% of cases. Escalation or delays and failure in escalation, 74%, and inadequate management or treatment in 4%. So they were the main themes identified. Incidents involving likely permanent harm, we had 50. The major injury types were different. The acquired brain injuries, vision, hearing loss, pressure injuries, testicular or ovarian torsion, vascular access device complications, and other. And reading that list, I think it's when you read the actual cases, you understand quite the severity. It was interesting, like the pressure injuries, you come across some cases where people expect a certain number, but it prompts separate thematic reviews, which I'll go on to explain why certain themes become more and more important as we review the data in a clustered fashion. So with regard to contributing factors, we looked at the human factors. So taking the death group, loss of situational awareness and cognitive-based errors were the two main themes. And with regard to the likely permanent harm group, in fact, that was just flipped. So it's not that clinicians and healthcare providers aren't thinking of things, it's how they're thinking about it. So it's a bit like the sepsis, where we all know about sepsis. It's just, do we think about it and do we actively rule it out? How do we approach it in our decision making? Contributing factors with regard to system factors, this slide shows both the death and the likely permanent harm. And so, of course, communication is was the greatest contributing factor, more likely to contribute to the death, to the result in the death of a patient, 87%. Inadequate coordination of care, unsurprisingly, and policy, protocol, or guideline failure. So they were the main themes that we discovered there. So overall, as we're reviewing these cases, certain things pop up, and sometimes you review a case and think, I've just reviewed this one, and then you realize it's a different HHS. And with my clinician hat on, I'll often think, this could definitely happen in my hospital. It could happen on my shift, later today, kind of thing. And so diagnostic error was a theme that we really explored, and we identified 20 SAC-1 events between the years. We just specifically looked at the years of 2018 and 19 in more detail, and we identified 10 statewide lessons learned. We looked at sepsis specifically through the years of 2012 to 2017, and we reviewed 28 SAC-1 events and identified 6 statewide lessons learned. And then vascular access devices, testicular torsion, plaster casts, or splint injury. So again, you don't think that's too dramatic, except for then you hear stories of children who are complaining about their leg or their heel being sore and presenting many times to many different types of clinicians and being told or ultimately being referred to a psychologist for pain management. And when the cast is taken down 6 weeks later, the child has a pressure injury that's down to the bone. So these are the kind of things we read, and then we read it again in another area. And so if we can make statewide changes and partner with the relevant people, we can establish the proper padding, the proper training, and it's all about partnering and identifying who those influencers and who has accountability and responsibility for the management of certain issues. We're currently working on the Children's Early Warning Tool. That has prompted some really useful discussions interstate with their vitals measurement tool. We all have slightly different versions of ones, but to see whether it was to review the cases where they have specifically named the Children's Early Warning Tool as a potential contributing factor to the outcome of the child. So that will be, the results of that actually are getting close, and we'll hopefully share that in a paediatric soon. So how do we share ours? Well, we write our reports, which is fine, but some people will read a report. I have to say, as a busy clinician, I may not, or I'll half read it or skim read it, or I'll put it in my to-do pile. So what we've done is we've tried to share our learnings in many different ways for many varied audiences. So on the left there, we've just put in a few of the pediatric matters. It's a one-pager. We put in a fictional patient story that captures the learnings of what we have found in the clinical instance. We capture the learnings, and then we put some really key resources. It's shiny, it's bright, it looks well. We find it everywhere, printed on walls, or people just look at it. It's easy, it's one click. That works very well for us, and that's probably the most effective way we've had of sharing our learnings to frontline clinicians. Of course, that's our report that we have there. We have some publications. For instance, the testicular torsion, that was interesting. So you have about 6 hours if you are presenting, if you have some issues and you present with acute scrotal pain. Boys often don't tell anybody. If they do, they go to a hospital. In adults, it's treated very, very differently to kids. So you'll get an ultrasound scan. In fact, you don't do that in children. That delays it. And so what we've managed to do is partner with the Royal College of Surgeons, with the radiographers and radiologists across the state to say, actually, if you're asked for an ultrasound of a child's scrotum, what is the clinical reasoning? And has a urologist or a surgeon been involved in the conversation? And finally, we were able to partner with the school nurses because we thought, well, if the boys don't tell anybody in the first place, then all this will be for nothing. So we managed to get an educational poster and a bit of package in the schools, which has been useful. And then finally, another partnership we're very grateful to have made is the Primary Clinical Care Manual, which is the clinical care manual across the state for more regional and more remote healthcare providers. And so that has really prompted, we just, whenever they do their updates, and they do them fairly frequently, actually, we just make sure that our learnings are captured in there. So thank you all so much for listening to us today. We're always very happy to reach out, to hear from anybody and to build relationships. It's so funny. There's a version of us interstate. There's somebody who does the exact same thing in a slightly different way in Victoria and New South Wales. And so over the years, we've been building those relationships. And it's quite interesting. Sometimes we'll do a cluster of something, think we have found world peace, and then realize actually it was also seen in WA or in New South Wales. And so we're building the relationships to share those learnings and to see what worked in one state, because our challenges are very different in Queensland than maybe in Victoria, geographically and culturally. So very happy to take any questions, and thank you very much for your attention.
Right, thank you so much, Sharon and Jodie. It was really informative and interesting. Thank you so much for bringing this to us. Happy to open it up to the chat or the Q&A for any questions, please. With bated breath. And Jodie, apologies at the start for not acknowledging you in the first instance there. I think I went full
No
Ron
worries at
Burgundy
all.
and sort of read my notes and didn't look up and see you on screen. So. Okay, I'll give it 1 more minute for questions to come through, if that's okay, if you don't mind holding. Here we go.
Oh, yes, I
Here we go,
see
good
Lynn
question.
McKinley's question there. Thank you. Yes, Lynn, in fact, probably over the last 2 years in particular, what we've done is we've realized that a lot of the clinical incident reviews actually don't involve GPs, and they can be a key part of the patient's journey and how they present, and missed opportunities along the way of communication, ED back to GPs and vice versa. And so we have GPs now on our clinical incidents subcommittees and on the steering committee, and they have a network. And so our paediatric matter goes out to the whole GP network in Queensland. And we've done quite a number of presentations for the annual GP conference for those very reasons. But it's interesting, it's prompted me on a few root cause analysis that we've undertaken to actually bring on board the GP, and that has been really useful in managing the messaging and understanding the issues in whatever case we were reviewing.
Great, thank you, Sharon Ann. There's a question in the chat. So you mentioned the early warning score as a theme. Was this an adverse outcome from using the score?
Yeah, it's a great question. So basically, as part of our questionnaire that we've developed, so it's about when you do your measure your vitals, how often you measure your vitals, what you do when you see the score that you get. So what happens on occasion is, and in pediatrics, it can be tricky. The skill mix can be varied. You try taking a BP in a 2-year-old who's screaming and trying to find the right equipment, or the mum's just settled the child. She said, please don't measure anything, give her another half an hour to sleep. But actually, the child's not sleeping. The child is slowly slipping away into unconsciousness. So what we've seen is there's a children's early warning tool where at a certain level, so 4, for instance, or 5, you're supposed to do certain actions like find somebody more senior, and then at 8, you're actually supposed to put a met call. But there are some barriers, human factors barriers, where, say, the child's in the emergency department and you have your registrar or your boss near you, you think you have the people, whereas in fact, actually putting a code blue or a met call out is the right thing to do, because you might just get someone else who'll come in and refresh and start asking questions. Could this be sepsis? Have we got those antibiotics in them? Have we got any access? Who do we need to call? So there are quite a number of common themes as you review the cases. It's often about vitals measurement, not specifically about the Q tool. And remember, the population that we reviewed, 73 cases, it's not massive, but it kept coming up as a theme. And so we thought it was very important to look about what are the learnings and where should we be going from here. And so one of the learnings that we'll head towards is the fact that, because we can see of our cases, interestingly, I think like 92, 93% have occurred in emergencies. And so I think that's because they get so sick, they decompensate there, and then they either end up in intensive care or they end up passing away. So it's not on the wards that it seems to be the reported challenges, is actually in the emergency departments or the pre-kind of hospital type setting. So, what can we do differently? How can we help? How can we, upskill, help clinicians be able to take a full set of obs? What counts as a full set of obs? When do you actually have to do the BP? Those kind of practical things we're really trying to strive to get the imaging, to get the messaging around. And so, for instance, as part of your safety netting advice, I see coughs and colds and flus all day, every day. So is that temperature the first of a very poor trajectory, or is it just like a cough or a cold and it'll be fine in a few days? However, if my safety netting advice, the pediatric matters as a QR code of the, pediatric sepsis parent information handout and you have that conversation, then parents know, instead of, oh, they're fine, they're getting better, or let her sleep, she needs to rest. Actually, if she isn't arousable, this is when you need to worry. And what does that mean to a parent? Because, you know, delayed capillary refill mottles, that means nothing. What is that in a parent's language? And also health literacy varies. And as we've seen from our population, it has to be culturally appropriate and safe for the families. So that's where we think some improvements can be made, but we strive to get it across the whole state rather than just kind of locally, because that's where we need the GPs, and that's where we have a rural remote clinicians there, because when I'm reviewing cases, sometimes I'll go, why don't they just do a CT? And they're like, yeah, so the nearest CT is 500 k's away. So, you know, it's about what fits for your own, you know, environment.
Right. Thank you. Thank you very much for that. I don't think we have any more questions at this point. So yeah, once again, thanks for your time, and thanks for sharing your knowledge with us. Thanks, Sharon, and thanks, Jodie.
Thank you.
Thanks for having us.
Okay, we're now into our final session before lunch. So this is genome testing in child death review and prevention by Dr. Joanna Garstang from the NHS Foundation Trust in the UK. So Dr. Joanna Garstang will present the final presentation in this session. She's based in Birmingham in the UK, so unfortunately she isn't going to be up at 3 a.m. to present live. So if you do have questions, please send them through via the Q&A, and we'll endeavour to provide you an answer via email. We'll shortly play the presentation. There is a slight delay on one of the slides, so don't panic if it sort of freezes for a few seconds there. Dr. Joanna is a clinical associate professor of child protection at the University of Birmingham, consultant community paediatrician and designated doctor for child death for Birmingham and Solihull. Her specialist areas are in safeguarding children, child death review, and sudden unexpected death in childhood. Joanna is chair of the Association of the Child Death Review Board Professionals and a specialist medical advisor to